Good morning. There's a lot of excitement in the room and a lot of excitement online, I'm sure. And it is my pleasure to welcome you to today's Mailman School Grand Rounds on the future of public health. I know the people in the room, but for those online, I'm Linda Freed, and I have the honor of serving as the dean of this great school. As you may know, I'm sure you do know, this year's Grand Round series has been and continues to be dedicated to the question of how we understand public health as a public good in and for society. So far, over the course of the year, we've devoted time to understanding the importance of investing in public health to more effectively create a healthier population, the ways in which public health serves as a public good, as the investment we make collectively in which everybody gains and nobody profits. Our discussions have focused on translating science to practice, promoting health equity, and the role of foundational core and local public health systems and services in our communities and in our policy as contributors to the public good, and even why health matters to the public's good. Today, I'm thrilled that we continue this conversation with a focus on the economic argument for public health itself and for public health as a public good. We know so well that in the last century, public health's achievements have included the host of issues, the full breadth of issues that are essential to human health, from the control of infectious diseases to improvements in maternal and child health, reduction in cardiovascular disease and other chronic diseases, reducing the toxins from pollutants, and so much more. And that all of these, if we add them up, have actually contributed to an astounding achievement, 7/8 of which are due to public health, which is having added 30 years to our life expectancy. However, unfortunately, even within our own field, we take these successes for granted. And the consequence has been too much that public health, which requires constant reinvestment and perhaps reinvention based on the science, the advances of science and knowing how to create health now in our longer lives. Instead, what we've seen is perpetual, continuing, and exacerbated disinvestment in public health. While healthcare spending in 2020 was 4 times greater than it was in 1960, spending on public health has remained constant dollars the same as it was in 1960, and has deteriorated to being less than 3% of our US investments in health. This disinvestment has led to more than constraining the capability of our delivery arm, which is the US public health system, has led to its weakening of its ability to deliver on long-standing needs, no less the ability to redesign and reinvent itself in the face of both incoming new needs for prevention and health promotion, as well as redesign of longstanding approaches. All of this has detrimentally affected the health of the US public. So while public health interventions have led to longer lives, what we see increasingly is people getting sick earlier and staying sick longer through those longer lives. This is the opposite of public goods. And we have to, and we all understand that we must learn how to reinvigorate both public health itself, to use the science of great schools of public health to transform our longer lives so they're healthy. But we also need to understand better how to make the case for the investments that are needed. So if the most important step is now to both reinvest in and redesign public health for the future, we need to understand the benefits we confer and how, as a whole, institution as a whole field, we can make the case for extending health across our longer lives and public health's role in that. It's estimated that by Trust for America's Health, that every dollar spent on public health saves $14.30 on healthcare and related costs. And even with this probably conservative and modest estimate, it's clear that public health is a valuable investment with tangible health and economic benefits. So it's time to ask ourselves important and transformative questions. Not just how could we invest in and better deliver health to the public to promote healthier as well as longer lives, but how do we invest in our society's ability to promote health for all populations, and how do we advance public understanding, political understanding and will in making those investments and in valuing the delivery of health to the public. So I can't think of a better partner than the one I have today and leader to have these discussions. And I'm thrilled to welcome Dr. David Cutler here to the Mailman School. David, we're thrilled you're here. Dr. Cutler, as I'm sure this audience knows, is the Otto Eckstein Professor of Applied Economics at Harvard University, and his work lies at the intersection of health economics and public economics. A perfect person to lead this discussion today. In the interest of time, because I could go on for 3 days about all of his accomplishments and accolades, I'll briefly introduce David. He has been an advisor on the Council of Economic Advisors and the National Economic Council under President Clinton, and was the senior healthcare advisor for President Obama's campaign. He's the author of books including Your Money or Your Life, Strong Medicine for America's Healthcare System, and Quality Cure. He has held esteemed positions in the National Institutes of Health and the National Academy of Sciences. And most of all, he is a thinker with immense stature on the issues, the big issues of our time. David, I'm thrilled to have you here, thrilled to welcome you, and thrilled to turn the podium over to you. Dr. Cutler will present an introductory talk, then I'll have the pleasure of having a discussion with him, and then we'll turn this over to you, the audience, to ask questions. David, welcome.
Thank you so much. It's wonderful to be here. You know, these days it's wonderful to be anywhere, but it's particularly wonderful to be here. And I feel like there's no way I can help but disappointing you after the very kind introduction. I don't want to lecture because I can hear myself lecture whenever I want. So I want to just really set the stage a little bit by giving you a couple of economic thoughts on the topic of public health and its relationship to public goods and kind of how I as an economist see that. And I'll sketch out, I think, a little bit of the research. A big theme of what I want to suggest is that actually, as a field, economics hasn't dealt with this enough. And so there are lots of open economic questions to which we should know the answer that we don't currently know. And I think this is valuable both for what it does for public health, but hopefully also valuable for what it does in terms of economists being interested in thinking about how to use their tools to understand these big issues. So let me start off first with what an economist means when you say public health. And so I want to think about 3 different kinds of goods here. One is a pure private good, my favorite of which is ice cream. The definition of a pure private good is something that the person who consumes it enjoys it and no one else gets to enjoy it. So it's sort of consumed and it's what's called rivalrous. So that is, if I consume the ice cream, you don't get to consume the ice cream. And if horrors upon horrors, you consume the ice cream, I do not get to have it. Second type of good is a good that has externalities. So one way or another, one person's consumption of it influences another person's enjoyment of life. And I'm actually going to distinguish kind of 2 types of externalities. The first one is what I'll think of as sort of a direct, but in this consequences, it's a health externality, which is if one person does something with respect to their health, that may affect the health of another person. So for example, if I smoke, then secondhand smoke directly affects you. And so that would be an example of that. Or slightly more subtle, but no less important, obesity was a risk factor for the spread of COVID-19. So having some people in a population who are obese contributes to poor health for others in the population, even those independent of their height and weight status, because they're more at risk. So increasingly what we're learning is that a community's health influences the health of everybody, and that's a direct kind of effect. The other type of external effect, which I'll also talk briefly about, is a financial one. That is when one person is, let's take obviously health as the continuing example. If one person's in better health, that affects the money that other people have to spend. And there it's very tricky because what happens in the short term may be different than what happens in the long term. And I'll come back to that. The limit of a pure public good is something like pandemic prevention. So setting up a surveillance system to watch for new viruses around the globe, new modes of transmission. There's the benefits to everyone are the same. So there's no way to sort of say, well, I get to benefit, you don't get to benefit. That is, it's non-excludable. So I literally couldn't exclude you in terms of benefiting from myself of not having COVID-23. Also benefits you in terms of not having COVID-23. And so the non-rivalrous, non-excludable part is what defines a public good. And the ice cream is sort of both rivalrous and excludable. That is, if I'm strong enough, I can prevent you from consuming my ice cream, but not the case with the public health. So that's the sort of typology here. And then the question is kind of how does one think about public health within this typology? And it has some features that are characteristic of a pure public good. Almost the classic example, what people used to use as the classic example of a pure public good was spending on the military. If you sort of spend on NATO, then you prevent attacks for all of the world and everybody benefits from that roughly the same and so on. But I think actually pandemic prevention is in some ways even a better example of that because it really truly is benefiting the entire world to prevent pandemics. And so anything related to surveillance, clean water, sanitation, water purification, all of those sorts of things are all sort of classic pure public goods. And what happens in one area has the potential to spread to every other area and to every other person. The externalities tend to be a little bit more in the individual and community interventions. And as I said, there's both a direct impact, which tends to be somewhat local, although not necessarily so in the sense that people in Boston are harmed by poor health behaviors in New York or helped by good health behaviors in New York, just as the reverse is true, but to a somewhat lesser extent, these tend to be a little bit more local. And the physical externalities depend on sort of what level they take place. That is, within Columbia University, there's some pooling of risk across individuals, so everyone pays if some are sick. That's also the case for New York City as a whole. It's the case for New York State as a whole. And of course, it's true for the nation as a whole. So there are mixed different levels at which these are carried out from pure for everyone to really quite local. Okay, so having done this is sort of kind of standard economics. Having done that, I then said, well, what is it that economics has to say about them? So I'll draw a couple of conclusions here. So the first conclusion is that the benefit of pandemic prevention is enormous. Okay, so if I come back to the pure public good aspect, the value of pandemic prevention is enormous. So this is from work that I did with Larry Summers. It was published in JAMA. It's on the cost of COVID-19. This was sort of done in 2020 based on like our guess of what would happen. So do not treat these as like hard and fast numbers. So that's not what this was designed for. This was designed to give you a rough order of magnitude of how to think about this. There are really two economic consequences of COVID-19, and they correspond to the two things that the dean was talking about that I mentioned earlier. One is the direct economic cost. That's the lost GDP part of this. That's how much less output is there because in a pandemic, people are not working, or if they are working, they're not being as productive, or they literally can't because it's a face-to-face job and we're not doing face-to-face activities. So that's the first part, is the GDP consequences. We muted the impact on individuals by borrowing and giving individuals money. Thank goodness for that. But that money does have to be paid back at some point. So the real economic loss is the lost in terms of output, the lost output that we no longer had. And then the second part of it is the health loss. And the health loss is absolutely an economic loss. So that is what people enjoy about life is not, some people enjoy going to work. I enjoy going to work. A lot of people do not enjoy the working part. They enjoy the consuming part. They enjoy having things to consume, both tangible things to consume and intangibles like health. And there's a well-established methodology that I'm sure is taught in a number of courses here about how to value that, premature death and long-term health impairment, mental health impairment, and so on. So we use that methodology to try and put some numbers on this. Those are not dollars like in a bank account, but they are nonetheless economic consequences that one can value. What we had here was we just tried to put some loose numbers on that, and the total turned out to be, our guess of what COVID would turn out to be was about $16 trillion. That is roughly 90% of 1 year's GDP. So it's kind of like saying nobody gets anything for a year. So that's like an enormous amount. No housing, no food, no clothing, no shelter, no entertainment, no nothing for a year. For a family of four, it's about close to $200,000. So just absolutely enormous amounts here. So the economic loss of pandemic is just enormous. And therefore the benefit of pandemic prevention is enormous. If you read sort of various on like how much would it cost to like revitalize public health or so on. I've never seen an estimate that I thought was great, but the estimates that are out there say something like, well, you know, if we want to improve our public health system, we should spend about, you know, $4.5 billion a year. So $4.5 billion a year, let's say I even took that over 100 years. So therefore I'm talking $400 billion a year, like $450 billion a year. Remember, I told you one pandemic is $16 trillion. So the order of magnitude is so off that like you could tell me it's not $4 billion a year, you could tell me it was $40 billion a year, and I would say no big deal. Like clearly spend the money. So that's the first thing that comes through economically, is that the cost of pandemic is so big that there's basically no argument for not spending more. I tried to do this calculation. I don't know whether you'd agree with me or not, but here's my rough calculation. And I'll sort of ask a little bit for whether you agree or not. What is the expected number of COVID equivalents or worse in the next 25 years? So you see my answer is 1. How many think 1 is okay guess? You think it's low? How many think it's higher than 1? Okay, so in New York City, I'm told that you're allowed to not vote. It turns out that think of yourself as being from Chicago, where in Chicago you vote many times. Okay, so I want you to imagine that you're in Chicago. Oh, come on. I want you to imagine that you're in Chicago. So I want you to vote. So your choices are 1 is too high, 1 is about right, or 1 is too low. Okay, so would you think that one is too high, that the number of COVID equivalents in the next 25 years is less than 1? Not a few votes. How many say 1 is about right? Not a fair number. How many say 1 is too low? Okay, so we're probably in between sort of about right and too low. By what fractional magnitude would better public health preparedness reduce the consequences? So I put in 0.25, so we're going to do the same voting. Remember, you are. So the other thing about this is it's not Florida. So you should vote for the thing you intend to vote for. Okay, so try to vote for the thing you intend to vote for. So how many say 0.25 is too high? The true number is lower. How many say 0.25 is about right? How many say the true number is higher than 0.25? Okay, so if anything, I'm a little bit low here. Okay, on both of those counts, if anything, I'm a little bit low. So I have 1 COVID equivalent with a 25% reduction gave me $4 trillion of benefit. Okay, and so I don't care how much basically it costs to revitalize the public. Like, I mean, I care in some broad level, but I really don't care. I don't care what you tell me it is. There's no case for not doing everything we possibly can do here. So that's the sort of the first conclusion that comes from this, is if you just take some estimates based on what we now know is likely to happen with these sorts of things about what is the impact, it justifies any dollar amount that you care to spend, any idea that you have we should do. The fiscal externalities are more difficult, and because there's a distinction between the short term and the long term. So let me think about smoking cessation for a second, and just think about the physical externalities of smoking cessation. So if you get someone to stop smoking, that's great because they don't have heart attacks, they don't have lung cancer, and those are both expensive. On the other hand, they live much longer. And people who live much longer just inherently get a number of diseases, many of which we don't know how to deal with. Some of which we do, but some of which we don't. So it turns out to be a difficult economic issue to model what is the lifetime impact of a preventive behavior. So not just the current impact, which you can often do because a healthier person spends less, but then over their lifetime. This was one attempt to do so. It's a paper, I'm one of the authors, but the real work was done by Dana Goldman here, creating a thing called the future elderly model, where it basically took various scenarios and said, how many elderly people would there be? What would they cost? And how would policies influence that? So for example, this is a paper that looked at 3 different scenarios. There was a delayed heart disease scenario. There was a delayed cancer scenario. The one that I want to look at, which is the one in red here, is delayed aging. So this is, we delay the onset of aging. Okay. Now, actually, this isn't really what you want. What you really want to do is to kind of create a rectangular life table, like you're in perfect health, and then you just sort of drop off like that. I call it the light bulb analogy, although I'm told that there are other versions of it. But this is not necessarily that. So this is delayed aging, and you get more elderly people. And of course, the thing to know about elderly people is that they are on net using more dollars from others. Okay, that's what we want. We want people at some level, at some point in their life, to be able to draw down from others, and at other points in life to be contributing. And where that line is drawn is obviously a big issue. But they're sort of using more services than others. What the sort of interesting thing that comes from this is that if you just took this version of delayed aging, which I haven't gone into that much detail about, but just give you a rough sense of it, this version of delayed aging actually increases total lifetime spending. Not in the short run. In the short run, it reduces spending by a little, but in the long run, having more people of an older age with the things we don't know how to address in older age turns out to be important. There's obviously a lot of issues here. Like, for example, in this scenario, people continue to retire at the ages they retire and receive benefits at the ages they receive benefits, and so on. For example, the cost here on the dollar end could be offset if people stayed in the workforce 1 additional year. Even in this scenario, there are health benefits which are not shown on this chart here. This chart is just showing you the dollar cost. There are health benefits, and the health benefits are way bigger in dollar terms than the cost in terms of spending. So the health benefits from this scenario are on the order of $7 trillion. The costs you can see here over, in a typical year are on the order of $300 billion. So nowhere at the highest year. So nowhere close to that. So it's still worth doing, but from the money, from the dollars in the bank account perspective, it's a more difficult calculation here. I would love to see more of it done. I think we should sort of look at the tools that we have as economists since then, and with combining that with more of a knowledge of public health to try and figure it out. So I will give you sort of 2 summaries, each of which, one of which the conclusion seems very strong and incontrovertible, which is there's no amount of pandemic prevention that's too much. Being healthier is beneficial. It has costs too. And so thinking about designing that policy is going to be a really interesting challenge for us as we go forward. And as I say, some of what thinking about this did was it made me consider areas where we could use more economic research. So I'd really love to see some more here. So I want to stop here because I've sort of just wanted to give you a little bit of a summary, and I'm delighted to kind of have a conversation about the whole thing. So let me end at this point.
We'll call on you in a few minutes. Because I just want to, first of all, thank you. That was a great entree. And I'd like to pose just a few more things before we open this up for the audience. Can everybody hear me, or should I use the mic? Use the mic?
Especially for the online folks too.
Yeah, good point. Better? Yeah. Hi, everybody. So that was a really fabulous framing on a really important issue, which, as you say, public health has a vested interest in developing further and understanding better. One of the huge, and I'd like to just ask you about a few dimensions of that, if I can. My sense is that a lot of the political discourse stops with one of the lines you had on your last slide, which is using living healthier is beneficial, but it's costly. And so what do you think? And sometimes what is the corollary statement from the political sphere is that, or even health insurance companies, is that if there is return on investment, that they won't see it in their political or health insurance lifetimes. So if we had answers that could help, what would the science be that needs to be done to deliver those answers?
Yes. Oh, I also have this on. People you're okay with this?
Yeah.
Let me deal with the two parts. On the private insurers, they do say that. They do say, well, I might invest in this and I'm never going to get the benefits. But then one of the, as everyone knows, the health insurance industry is consolidated, so there aren't that many health insurers. And so what they then also say is, by the way, if everyone's doing it, I'm comfortable with that. So if you say, look, I want you to be the only one who invests in smoking cessation and so on, I'm in trouble then, because I'll get all the smokers too. But if you say we're all going to do that, then we understand that that's something that we all need to participate in. And again, that's the classic public good. That's if we all get together, we can all solve this problem that none of us would do it individually. So I think that part, I think people have come to recognize enough. And if you say, the insurers didn't really quibble with you can impose limits on how much people can spend on your policies, as long as you're all doing that. The political thing is sort of harder because, on the one hand, people care only about the dollars, like when you talk about Medicare, dollars and Social Security dollars. On the other hand, if you then say, okay, so we should basically just take, if the trust fund is going to only have enough money to pay 2/3, the Medicare trust fund to pay 2/3 of the cost, we should just say, okay, randomly, we're not going to pay for 1/3 of all the hospitalizations, right? People go apoplectic about it. And so when people really do want to have the health benefits as well. And so I think partly it's that one of my hopes, if you will, is that having the numbers helps, that people really see those numbers really are big. And just because they're not in someone's bank account doesn't mean they don't count.
So the conversation often is prevention is too long-term an investment. I'll never see it in my political life cycle. Do we need an economic science of the short and intermediate term returns on investment from investing in prevention at a population level, particularly?
I think we do. Do we need, and I think in some ways COVID helps us a lot because again, come back to the obesity example where people who are obese were more likely to get COVID and then they spread it to others. So I think you say, well, look, even if obesity prevention is a long-term effort, every step we take means that the next COVID-24, COVID-25 is less likely to affect everyone. And so you will start to see gains on that right away, even if in the short term, you're not going to see those benefits or the benefits of smoking cessation or vaping reduction are not going to appear for some time for those individuals and their own spending. It may very well influence how bad lots of things are in the interim on that. I also think for some cases, even small short-term benefits can have enormous impacts. So for example, just take one thing related to smoking, which is vaping, youth vaping. The youth vaping will hurt the kids down the road. Not too many cases of lung cancer will occur at age 18, thankfully. On the other hand, it's draining a ton of money from schools to address vaping now, because now you need vaping officers and have to be installing cameras and so on. And that is like a direct, you can either spend the money on teachers or you can spend the money on vaping equipment. And so that short-term trade-off, even though the dollars aren't big, if you could say, yeah, we could do something about vaping and then those schools have those dollars back, that's a really, really big issue, even though the dollars are not that big. Like you know, Bill Gates could write a check and like fund it all and he'd still have money for dinner. You know, you could still alleviate a short-term funding issue very substantially.
So I'd like to think about another dimension of this and get your thoughts, which we've talked about a little bit in the past. And that is that public health is responsible for 25 of the 30 years of longer life that we're all getting to live. And that's an immense human accomplishment. And we've demonstrated lots of things. I mean, the US's natural experiment has been to demonstrate that if people are the beneficiaries of the conditions across their lives that promote health, we're able to live long lives with health. That's a remarkable learning of the last decade, which we didn't know before, but we don't democratize those conditions. But I've been observing in the last month that the papers have had a huge number of headlines from a number of countries, starting with China, saying that this is a disaster, that we have all these old people and not enough young people. What if we thought about this, the return on investment of investing in health differently? Could we do that? For example, if we said that if people live long lives with health, they actually are likely to contribute to societal well-being for longer. Is that a cogent economic argument?
So there are all sorts of issues buried there. From the direct question of could people contribute longer? Absolutely, yes. One of the things that we did in the US is we increased the age at which you could get full benefits for Social Security. And that had a very big impact on people working later in life, along with a good job market and so on. The reason, this ties with the public health argument, the reason why I, for example, am leery about going higher across the board is because health differences are so great by socioeconomic status. And they're changing so differently by socioeconomic status. So high-income populations are living much longer and healthier, and low-income populations are not living much longer and not much healthier, although in some dimensions, yes. But in general, not much health. And so it makes very little sense to increase the age at which one is eligible for benefits if there's a large share of the population for which they're not living longer. So the only way I would consider raising that age would be if we do something that's going to help people in the bottom half of the income distribution be able to live longer, healthier lives so that they both can contribute and are, you know, and still maintain a sense of security in old age. So I think that without coupling those two, the live longer component, we by all means, high income people should contribute and are able to and want to often contribute more. But to do that of everyone, we have to be investing in everyone's health.
Which of course is a huge responsibility and necessity for public health leadership.
Oh, absolutely. Absolutely. And in some sense, I think the era in which we think about the population, we need to move away from that for a while because the population is too heterogeneous, both in levels and trends now. And policy would be better served if we thought about populations rather than a population.
Now, your and my friend David Bloom has provided evidence for a different dimension of contributions than just thinking about Social Security and Medicare, and that is that an aging population makes already huge contributions to the productivity and well-being of a nation through working longer if people want to and are able to, and through voluntary contributions and service to community. In fact, David estimated, as you know, that an equivalent of 7% of the GDP of the US and 7% of the GDP of the EU is contributed by the contributions of older people. Now, why am I bringing this up? It's obviously because that's the argument against investing in longer lives with health, is that we live longer and then we cost money. But supposing we could actually amplify people's ability to make those contributions because they're healthier, would economists think differently about the ROI here?
Oh, absolutely. So the fiscal ROI, absolutely. You know, from the individual perspective, people like to live longer, healthier lives. And so there's both the direct, that is also a social benefit, but that's a benefit to the individual as well. And then on the fiscal side, there's that. You know, the other thing that most countries don't think about on the fiscal side, which is extremely important, is if you really wanted to do something about, for example, funding difficulties in Medicare and Social Security and so on, you would have a much more liberal immigration policy. Because immigrants enter at almost exactly the age where they then start to pay taxes and contribute more output and provide really, really valuable services for people. So every country that complains that they're getting old and they have no idea what to do, you know, those countries, the ones that complain the most are also the countries that are most fearful of foreigners. And that's no surprise that those are related, but that would have it like an immediate impact on the economy as well. So there are ways to think about the fiscal consequences. There are many, many ways to think about the fiscal consequences. At heart, the way that I think about the investment in health is that it creates a lot of opportunities for you to do stuff. Opportunities to have people live longer, opportunities to have people contribute in different ways. And like, as an economist, you never turn down an opportunity because you can always do things to offset whatever the side effects of the opportunity, but you'd always love to have that opportunity.
So my last question before I ask for all of you in the audience to ask your questions is the following. New Zealand did a very radical thing a few years ago and changed their social compact. And they said that our goals as a society should not be our GDP. Our goals as a society should be human well-being. And that's how we should measure success. What would well, that's for the United States, probably a more than radical example. Are there any lessons here that are feasible and realistic for us in our thinking about this?
Yeah, it's the British have also moved along those lines as well, as you know. It is absolutely true that the goal of a society is not to have a higher GDP. So for example, one way that the economy could have a higher GDP would be if we all worked, not whatever we work, but twice as long, because then we would produce more. Something tells me that wouldn't necessarily be a better society. Or still another way to increase GDP is to have a major earthquake that knocks down buildings and then spend a bunch of money rebuilding the buildings. That's a tremendous way to increase GDP because of all the stuff that goes into it. At the end of the day, you're no better off because you just have a building. And what you've done is you've wasted a ton of resources, which is you've had people rebuilding a building that ideally wouldn't have fallen down in the first place. So there's no sense in which GDP is a good, complete summary measure of welfare. We like it because there's some things like when GDP is higher, that means there's more stuff and we like to consume and enjoy stuff. But we also like the health benefits. We like environmental things. We like neighborhoods that we can enjoy. We like not having crime. Many of those are things that the enjoyment of them actually reduces GDP, but that's okay because that's what we like doing. If you look in the cost, you know, that I showed of COVID, half the costs were health costs. And again, that's a real economic loss. It's not measured in GDP. And I think, if anything, the world fixates on GDP more than economists want the world to fixate on GDP because it is not the measure of how good we are any more than if you have less income than your neighbor, are you a less good human being than your neighbor? There's no sense in which that second follows from the first.
Well, thank you. Well, Professor Baer is waiting in the wings to be the first questioner. So we'll turn to Ron, and then there's a mic to wander around for other people's questions also.
So I actually want to build on the last comments by both of you and return to the issue of smoking. For years, those who argued for really tough measures on smoking argued about the social costs of smoking, billions of dollars on healthcare, et cetera. Then an economist at Harvard named Chip Betzguzi ran the numbers and said, well, actually, it turns out that smoking saves us money because people die sooner. Well, that posed a huge challenge to the anti-smoking people. What's the argument for controlling smoking? And Ken Warner, another economist, said, we were wrong all along. We never should have argued for smoking cessation because it would cost us less in medical dollars. We should have argued for smoking cessation because it saved lives. The question I have for you is the advantage of trying to translate the good, the public good of longer, fuller lives into dollar amounts. Why not just recognize that that is a good that we want, and translating that into, by costing it out, just misses the point about how human beings experience their lives.
So it's a great question. Let me actually just give you a couple of numbers about smoking and see if this helps. See if this helps anyone's thinking in the audience. It is in fact the case that a lifetime of smoking and a lifetime of not smoking roughly has virtually the same impact on the amount of money that a person contributes to others and takes from others. So Kip Viscusi's work actually built on work by some of my other colleagues, Joe Newhouse among them, that if you were going to tax cigarettes based on how much they added to the cost of others, the tax on a pack of cigarettes would be something like 10 or 15 cents. But now let me do the other experiment. So how much more does the person live if they're not smoking? Okay. And it turns out that every pack of cigarettes, if you're a regular smoker, every pack of cigarettes reduces your life expectancy by about 2 hours. And if you price that out in some fashion, that turns out to be roughly $30 a pack in terms of the lost benefits to the person. So you might say that, how much should we tax cigarettes? Well, if we're trying to get people to recognize the harm they're doing to themselves, maybe we ought to have a tax on cigarettes of $30 a pack. Well, maybe not the whole thing, because some people recognize the harms and they still choose to smoke and so on. So maybe it ought to be $15 or $20 a pack. But that kind of calculation, I at least find helpful to think about, what is the range? So when New York taxes cigarettes at, I don't know, $6 a pack or whatever is the tax, is that excessive? Well, not if you think that the person's harming themselves $30 a pack and you're trying to help the person do what they want to do. Maybe that's not so excessive. So for some things, I think it's helpful to have a number. And then you can say, well, $6 a pack isn't that excessive because this person's doing something which is costing them much more than that. And they probably don't want to be doing it. So I'm helping them add that much to their life. So I think it's not definitive, but I think that way of looking at it sort of helps sometimes.
Anybody want to respond to that before we go to the next question? No? Next question. I'll give you my mic.
Thank you, sir. One is a political question. Why do states that can benefit stagnant states like the South, conservative states that can benefit from public health are against this move? And the left, right? I mean, they are against climate regulation, they are against healthcare. I don't understand that. The second one is high correlation between, there's a stagnant labor productivity. It's a global issue, and especially in the United States. Is there any correlation between stagnant labor productivity and healthcare?
Those are both excellent questions. Each one worthy of several hours of discussion. So I think, but they're related in the following sense. One of the unfortunate things, I say unfortunate, one of the unfortunate things is that our willingness to help others is income related. So people get more generous as their income goes up. So for example, the demand for health coverage in a country goes up as people get richer. and people's willingness to spend on public health, I think, is somewhat higher as they get richer, even though the consequences are often bigger in a low-income country. And so some of what I think about different states and so on, and also about the income issue, is that in an era where a lot of people feel their income is stagnant, they say, I'm not sure I'm willing to devote money to public health. Whereas if they think that things are getting better and that the future looks rosier and that their incomes will be higher and their kids will do better and so on, then they're willing to devote more resources there. And it comes back to the discussion we were having about, for a lot of people, particularly in the bottom half of the income distribution in the US, they don't feel their lives are getting better. And so if you say, well, we're going to take money and invest in public health, they say, yeah, right, but I need that because my incomes are not otherwise going up. And so at some level, it's hard to have the public discussion without having a broader income inequality discussion. On the other hand, it's not clear that broadening public health to include all of income inequality is that helpful for the political debate either. So it's sort of trying to find a spot where you can say to people, this is worth it, here's why. And we're also going to be doing other things to help you, but you need to recognize that this is something that's helping all of us, is where in my mind, I try to be.
Thank you. Professor Munich. Hi, Mike. Oh,
Can everybody hear me? Probably not on Zoom, so you should probably get it.
Thanks so much. And I really love this discussion, and I've been following your work for many years.
Thank you.
And some of the work you've done is on
Not even
efficient.
my mother would say that.
I bet you she would. So some of the work you've done is on efficiency. And I guess the question is, are we spending our money well? You know, we have if you think about it at the county, state, and federal level, we have 100 different health systems that are not interoperable in terms of billing and EMR systems. We fax forms back and forth today about COVID cases, still using fax machines, which for the younger people in the audience is a machine you put a piece of paper into. And you know, we had 9 agencies investigating the laboratory hypothesis of COVID outbreak. So are we spending this money well, the money that we do have now well, and how might we spend it better in public health?
So let me broaden your question to in medical care and in public health. Especially in medical care, the answer is no. Like the fact that things have to be faxed. The only use of fax machines now in the world is in healthcare, as best I can tell. There is literally no other use case for a fax machine. So that's awful. In public health, because the dollars are smaller, the waste is surely smaller. I am a little wary about centralizing everything, in the sense that that sort of means that if that one central thing fails, then everything fails. So I go back to, you know, early in COVID-19 when the CDC made their tests, you know, that there was contamination of one of the reagents, so the test didn't work. At least part of the test didn't work. And okay, that happens. That sort of happens, you know, things make mistakes. But if that's the only way you have to test, then if that one thing fails, you're in big trouble. So it'd be as if there were literally only one open heart surgery facility in all of New York. And like if the power went out, nobody could have open heart surgery, or nobody could have, you know, whatever it is. Like that's a terrible way to run things. So you need to think about some redundancy. On the other hand, having things so decentralized that, you know, the easiest way to get, you know, information from, you know, from east of 6th Avenue to west of 6th Avenue is to, you know, hire a courier to bring it there and stuff like that. Like that's like just absurd as well. What healthcare and public health has not been very good at is dealing with information. And, you know, in some sense, you know, like what information technology is about sharing information. And healthcare and public health is so awash in information that it hasn't figured out how to use it well. So I think there's just incredible need for people who can figure out how to get information where it needs to be, and not just get the information, but then make sure that the actions that you want to take happen. And they happen sort of by default, not because someone then sort of makes them. So sort of making everything that is routine happen routinely is a big deal. but I'm not a big fan of over centralization.
So other questions? Since the mic's there, and then we'll go to the one in the back.
Great, thank you. Fascinating as always. So I wanted to pick up on two remarks you made. One, that it's impossible to spend too much, almost impossible to spend too much on pandemic prevention. And then the second, which the dean touched on as well, that it's not money in the bank. And the question is, which you know, I agree with both of those. The question is, right? You can make that argument for a lot of different things, right? So public health isn't the only potential public good out there. So I think, you know, the Murphy and Topol book on medical research, I think you have a chapter in there doing some sort of similar exercise suggesting, I don't know if it's you or the preface, but that you could, you know, triple the NIH budget and, you know, if it reduced cancer risks or the risk of getting cancer by 1% or something would be worth it 100 times over. I don't know if I got the back of the envelope right, but you could do that for like nuclear nonproliferation, climate change, asteroids hitting the earth. You know, at some point you start talking about, and so the question then is like, how do you think about that public health relative to other competing public goods? And then, you know, both from a political economy perspective, but also just fiscally, like, you know, where do you get the money in the bank? And the second is, you didn't quite touch on this, but a lot of the examples in public health, but also those I mentioned are global public goods. And how do you think about the global coordination and global collective action issues?
Those are both great issues. Both public health and the NIH have the virtue that on the scale of the economy, they're minuscule. So you could actually do the two of those. But I want to come back to your broader point and make two observations. One is, and this comes from the book that I did with Ed Glazer recently on survival of the city. I think there are three great global challenges. There's nuclear war prevention, there's climate change, and there's vaccine illness or pandemic. And so those are the three I would spend my money on. But what's interesting to me about that is by far and away the hardest of those three is the pandemic prevention. Because nuclear war, there are only 10 countries in the world that can do that. And climate change, you're basically dealing with rich countries because there's not much climate change that happens in poor countries. So like those are sort of rich country problems. And yet we've made much more progress on the rich country problems, maybe because they're only rich country problems, than on the pandemic problem. So we drew a contrast in the book between how the world handled COVID-19 and how the WHO, if you want to think about the relevant world institution, how that handled COVID-19 versus how the world handled the threat of nuclear war. And the organization that was most responsible for that was NATO. NATO was about as successful as any international organization has ever been. So we literally said in the book that we should think about global pandemic prevention, not so much as WHO, which always has to beg for $1 here and $1 there and can't be mean to the Chinese because the Chinese are funding its money and can't announce an Ebola outbreak in West Africa because it's afraid of hurting tourism and stuff. NATO never worried about tourism in the Balkans and never worried about, offending France. But NATO had. So that maybe what we should do is set up an international institution on pandemic disease that looks more like NATO than the World Health Organization. Not that the World Health Organization is bad. I mean, it did underperform. That's universal agreement. But it also underperformed because the structure of it is set up in a way that living hand to mouth isn't the way you fight a war. And if we're going to have to think about the world fighting a war to prevent pandemic disease, which we clearly have to, we need to think about it that way.
Thank you. There was a hand in the back. I can't see who it is.
Hi there, I'll stand up. Thanks so much for being here. Just a question with respect to stimulating public demand for investment along the lines of what you've described. I'm thinking about whether we call it bounded rationality or cognitive bias or distorted risk evaluation. There's a need to mitigate that in policymaking, whether in response to constituents or even just for policymakers to understand the value of the longer term investment. So from a communication standpoint, I agree with you and think that a defense model for public health probably will carry the day. But, do you have any strategies for public engagement around overcoming cognitive biases and limitations?
So my sense of politics is not very good, which is why mostly I'm in Cambridge and they took away my visa to visit Washington, DC. So I'm not allowed to go there. So it generally is not very good. But one thing that I'll give you two data points that may be helpful. One is there is a lot of interest now in what can we do to prevent the next pandemic. And I think if someone had a plan for how to prevent the next pandemic, and part of that plan can't just be monitoring wet markets in China and monitoring Ebola in West Africa, because a part of it has to be improving the health conditions in Brownsville. I think, did I get Brownsville right? In Brownsville, so that, because really you're just one subway ride away from exposure to disease in Brownsville, even if you don't go there. So thinking about pandemic prevention, I think like if someone had a coherent plan for would be great. The second fact I'll give you is, as the dean mentioned, I was involved in the Obama campaign. So I was a senior healthcare advisor for 2 years when he was running for president. And you might remember that the Affordable Care Act had a prevention and public health trust fund. The way that came about, I know because a version of that was something he had proposed in the campaign, so I know about a version, I don't know about the final version, was that given that you're spending close to $1 trillion on insuring people, you ought to spend something on public health. And the problem was there was no plan that was out there that was complete with a price tag and a set of benefits. So whereas on the health insurance end, people had done a lot saying, okay, we need to cover everyone. Here's 3 different ways to do it. You could choose your favorite way. Here's what way A would cost. Here's what it would involve. Here's what way B would cost. Here's what it would involve. Here's what way C would cost. Here's what it would involve. Choose what you want to do. Choose, there's a little bit of mix and match, but fundamentally, this is what you do. When I went around to folks at the time in the public health world, and I said, okay, suppose you were going to do 10 or $15 billion a year, what would you do? The answer was, well, we're not quite sure. There's some programs, but nobody's really put it together. Maybe somebody has now, but if somebody is not now, I would put together like, we need $13.5 billion a year for the next 18 years. This is where the money is going to go. This is what it's going to buy us. And this is how it's going to contribute to stuff. And then try and rally people around that and then make it be, we need to do this. This is the plan that everyone agrees we need to do. These are the 2 plans, choose A and B. When I've tried to look recently, I found a lot of, well, it would be nice to do a little bit more here and a little bit more there and so on. And that's how you get $4 to $5 billion a year. But that didn't strike me as a plan that was like, no, here's what we should do. It struck me as, here's what we could cobble together if we got to cobble together something. And I'm not in the business of cobbling together. That's why they don't let me go into Washington. I'm in the business of like, what would it need to actually solve the problem? And so I would literally put together, what do we need to solve the problem? And then say, how are we, this is what it's going to take to solve this problem. If you don't, expect COVID-24 and COVID-33 and all the rest. And so that's your choice. And go, now which side do you want to be on, and go for it.
So on that note, I mean, you're spinning off 30 other questions, which I wish we had time in this setting to ask. But I know that
so I don't
yeah,
have to answer.
right. But we'll get there. But in the meantime, I know that our formal time is up. It has been fabulous to have this conversation. I think that we recognize that this is hopefully stage setting, not stage defining. And that there will be many others who will join in on this. David, thank you.
Thank you.